Sir, with all your permission, shall we start this session?
Yes, please go ahead.
So you can turn on your camera so that we are live now.
Yes, I.
Yeah. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Manoj Toshniwal, sir. Sir has done MBBS, MD, DM in clinical hematology and consultant hematologist at Jeevan Amrut Hospital, Aurangabad. Today, sir is going to discuss on a topic hemophilia, an overview in World Hemophilia Day. Let me tell you overview of the topic. This year, access for all, prevention of bloods as a global standard of care is the theme of World Hemophilia Day, observed on 17th April. Hemophilia is an inherited genetic disorder that impairs the body ability to make blood clots, a process needed to stop bleeding. To more know about this session, I would like to invite sir and hand over this session to sir. Sir, over to you. Kindly proceed from here.
So first of all, at the outset, I thank team MedTalks who have arranged this talk for good. I thank all of you joining discuss today hemophilia, and I thank Faraz for such a kind introduction. Today, 17th April, is the day which is observed as World Hemophilia Day. जागतिक हेमोफीलिया दिन. इस दिन, on this day, it is to remember that hemophilia is a disorder, to make public aware about the hemophilia so that they can lead a good and normal life. Hemophilia is a genetic disorder, and we do have more than 50,000 patients in India who are suffering from hemophilia. Actually, most in the world, but still, many of our colleagues, doctors, don't know about this disease because we have never heard, we have never seen those cases. And that is why we chose this day to talk on hemophilia and overview. Treat fast, treat safe, because this is a bleeding disorder where patients start bleeding like anything, and that is why to keep them safe, we need to treat them fast. And to treat them fast, we must know about that disease, at least something. So, what is bleeding disorder? Bleeding disorder is a group of hereditary bleeding disorders in which there is a deficiency of one of the factors necessary for coagulation of blood. In our blood, in MBBS days, we must have learned that there are 13 different factors, factor 1, 2, 3, up to 13. And in those 13 factors, 8 number factor, if it is deficient, we call it hemophilia A. It is the most common disorder, and hemophilia B is factor 9 deficiency, which is lesser than. Other factor deficiencies are also there, like fibrinogen, thrombin, factor 13 deficiency, factor 11 deficiency, factor 12 deficiency, factor 5 deficiency, factor 7 deficiency. These are rare. But hemophilia A, which is factor 8, and hemophilia B, which is factor 9 deficiency, is quite common, and that is why usually we call all these disorders are hemophilia, where it is the hereditary bleeding disorder in which deficiency of one of the factor is genetic because of some mutations. Normal clotting process require these factors, but people with hemophilia don't have that factor in blood, and these are X-linked disorders, hemophilia A and hemophilia B both, particularly hemophilia A. And in hemophilia A, as it is X-linked disorder, is mainly seen in, or only seen in, I can say, male patients, because females being double X, they are usually heterozygous and they don't have that symptom of hemophilia always. They are carrier, and if they are carrier, there are high chances that they will carry that gene to their kid, 50% chance. And that is why usually this happens to be from the maternal side. Hemophilia are X-linked disorder. And this factor being unavailable in the blood, clotting process is longer than the normal, and that is why these patients start bleeding. So, just to understand the epidemiology of this disorder, 1 in 7,500 live male births. Hemophilia is also called as royal disease because this disorder was in the or is in the, the England, the Queen Elizabeth, the English queen, in her clan, and that is why this disease is called as royal disease as well. So it runs in the family, usually from the maternal side. So incidence is 1 in 7,500, but usually in almost 70% of them, we do find some or the other family history. 30% of them can also come even without family history as well, because usually it is because of the incidental mutation in those cases. So the genetic mutations, as I have already told, in India, usually incidence is same, but because of prevalence, cases are more than 50,000 cases of hemophilia we have all across India. As compared to US, almost 4 times. That is why India is the capital of hemophilia, but still not much of care is available because we don't have awareness. Degree of severity wise also we usually classify them. Normal factor 8 or factor 9 level in our blood is usually 50 to 150%, somewhere around 70, 80, 90, 120, 130% as compared to normal. Whenever it is between 6 to 50%, it is mild hemophilia, and usually they don't bleed. Up to 5% is good enough, unless they have a surgical stress. So if some surgery needs to be done, those mild hemophilia patients need some treatment. Moderate hemophilia is when factor level is between 1 to 5%. It is fixed throughout the life. It never changes in our body. So if the gene mutation is of type that it is moderate hemophilia, they have factor 8 level which is 1 to 5%, and they usually bleed whenever there is some injury. And severe hemophilia is when factor 8 or 9 level is very low, less than 1% or nil, and they can bleed spontaneously. So severe hemophilia, spontaneous bleed, factor level less than 1%. Moderate hemophilia, bleed after injury, factor level is between 1 to 5%. And when factor level is more than 5%, up to 50%, it is mild hemophilia, and they have tendency to bleed during surgical stress only. Rather than that, usually they are asymptomatic throughout life. What are the types of bleed usually they have? Usually, most common type of bleeding which they have is joint bleeding, and that is the concern. The spontaneous joint bleed in hemophilia patient can lead to the chronic joint arthropathy, leading to chronic disability for life. That is why this bleeding should be stopped to lead a normal productive life. Classically, a patient of bleeding disorder, if they say that I am having recurrent swelling in elbow or knee joint, large joints of our body, it can be because of hemophilia. First, we should do PT, APTT. If APTT is high, that means more likely he is having factor 8 deficiency, because incidence wise it is more common. We do factor 8 assay. If it is normal, then we do factor 9s. If APTT is normal, then we look for some other cause. So usual bleeding symptoms are joint bleed. Large joint are usually the one which bleed. Muscle hemorrhages are also common, particularly the retroperitoneal muscles. Retroperitoneal muscle, because of some twist in the leg or some running or some injury, they can have retroperitoneal bleed, which can make them bedridden for some time. So that is also one of the symptoms in this hemophilia patient. Soft tissue bruises, sometimes some injury can lead to the muscle bleed. That is there. Rarely they can have a life-threatening bleed like severe GI bleed or intracerebral bleed, which can lead to the intracranial bleed, which can lead to the death. Other mouth bleed or gum bleed or nose bleed, mucosal bleeds are less common. Mucosal bleeds are more common in patients who have platelet dysfunction. If coagulation factor is at the problem, usually they have muscular or joint. They do have aura-like symptoms before starting bleeding, like tingling or bubbling sensation in that particular joint. And then that joint starts to swell. It is painful, tender, and warm to the touch, leading to the joint disability. And that is why one must judge that someone is having that joint bleed and start treating them. This is a classical hemophilia joint bleed where this patient has right knee swollen to the extent that you can see the veins. And this is called as classical hemarthropy. So early signs of joint bleeding like bubbling, tingling, or heat in the joint, and then joint starts to swell. If it is chronic swelling and recurrent bleeding there, usually there is bogey filling to the joint and there is limitation to the range of motion, leading to the disability. And that is why before they develop disability, one must treat them. Sometimes patient develops bleeding recurrently on the same joint, and that joint is called as target joint. Once bleed is there, that deposition of the hemosiderin make them more vulnerable to the second bleed. Second bleed make them vulnerable to the third bleed, and they spontaneously keep on. More likely it is in the knee, ankle, or the elbow joints are the most common. Sometimes they can have this muscle bleed also. This patient having thigh muscle, left thigh muscle is swelling and there is bleed. Similar to the joint bleeding, but usually there is tightness or shininess to the skin. And it is very painful, more painful as compared to the joint bleed. And there is significant blood loss also whenever there is muscle bleed. And in those cases, you need blood transfusion as well. Usually it is leg, calf, or the, as I've already told, retroperitoneal bleed. And in those cases, it needs to be treated as early as possible. Sometimes they can have this soft tissue bleeding as well, but particularly whenever there is some injury, and usually no treatment is needed to them. If it is soft tissue bleed, just apply some ice, make them comfortable, give some tranexamic acid, that is good enough. But whenever there is joint bleed or muscle bleed, they need to be treated urgently. Other bleeds are less common, like head or intracranial, which can present with nausea, vomiting, headache, visual changes, drowsiness, or even loss of consciousness. Neck pain can be there whenever there is neck bleed. Abdominal pain or ileostosis, there is usually tingling sensation or decreased hip range motion, common. Other bleedings like mouth, nose are less common in this patient. So let's come to the final part of this discussion. What is the treatment of these patients? So replacement of deficient clotting factor is the single most important step in any intervention. Early and appropriate treatment of each bleeding episode is very critical to minimize immediate and also the long-term complications. Recognize the bleed and treat the bleed as early as possible. Whenever a child comes with a swelling in joint, Without wasting time in investigating, immediately give the factor which is deficient. First, confirm whether it is factor 8 or 9, and then, as per the dose calculation, usually it is 30 to 40% required. That is around 500 international unit of factor to the average adult weight of around 30-40 adult child weight, and it is sufficient. Factor is usually administered intravenously, slow IV infusion, and it is simple, and most of them receive this factor at home care or daycare centers only. Along with that, usually they need some other measures like good analgesia. They can use paracetamol, tramadol, and if factor is given, even diclo or ibugesic as well. It is called as a race to the joint. Rest means that joint should not be moved. By applying crepe bandage or some support, we should immobilize the joint so that further bleeding can be stopped. Ice application. Ice causes vasoconstriction to the blood vessel, leading to the less bleeding. So RI. C is the clotting factor replacement and compression. Compress that particular joint so that bleeding stops. If gum bleeding there, compress that and clotting factor. And E is immediately shift that patient to the hematology care without. So usually it is the ice application is also important, and this mnemonic can be remembered as RICE. Some patients do get prophylaxis if they develop recurrent bleeding. They can go for prophylactic transfusion or infusion of these factors, and prophylaxis is usually given to prevent the regular bleed. So activities wise, unless patient is recovering from a bleeding episode, they can participate in regular gym class, they can go to the planned field trips, they can use routine activities as well, and usually we avoid them contact sports where they can lead to the bleed. Otherwise, they should go for cycling, swimming, and other activities which can strengthen the muscle, which leads to the less bleeding in the future. Things to be considered: usually keep factor ready at home, keep your blood reports ready at home, keep your diagnosis understandable to the caregiver, and as early as possible, reach to the primary caregiver. So this is overview about hemophilia. So hemophilia is a bleeding disorder. Mild, moderate, and severe we have considered. Factor 8, factor 9 we have considered. How exactly X link get affects to the child. What are the major symptoms and how exactly we treat them? What is factor infusion? How to calculate the dose? How to infuse the dose? How to give prophylaxis? That is all we have discussed today, and this is all from me. So its session is open for the question and answer. Thank you for us. This is all. Over to you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session, as this topic was one of the most important topic to be discussed, as we are found lots of people with this disease. Sir, we have received some question from the participants. If you allow, can I take this
Yes,
question with
please,
all your
just for
permission?
us.
Yeah, the first question is, what are the differences between mild, moderate, and severe hemophilia?
Thank you for asking this question. As we already discussed in the during the discussion, mild is the one where factor level is between 6 to 50% somewhere. They bleed only with the surgical stress. Moderate is less than 5% but more than 1% factor level. They bleed only after some injury. And severe hemophilia is factor level less than 1%. And they bleed spontaneously also in the joint. So this is how we classify the hemophilia: mild hemophilia, moderate hemophilia, and severe hemophilia. Yes.
Okay, thank you so much, sir, for answering it really well, sir. Moving forward, I can see another question. The question is, which condition should be included in differential diagnosis of hemophilia A?
Very nice. Thank you so much for asking this question. Usually, the diagnosis is clear for this patient because most of them have family history of hemophilia. If some child comes with a history of or symptoms of bleed in the joint, elbow is swollen, or the knee is swollen, or ankle is swollen, tender, we consider them as hemophilia. We first do PT APTT. APTT is prolonged, then factor assay. Family history is very important, but usually 60% of them have family history, 30-40% may not have the family history. And other things, then the infective joint disorders, even some injury, the local tumors, those can be there which can lead to the bleed in the joint. But usually it is the hemophilia which comes. Is all. Thank you.
Okay, thank you so much, sir, for explaining it really well, sir. We will be taking few questions. And the third question is, sir, does having hemophilia restrict a person's lifestyle?
Thank you for this question. In India, yes, having hemophilia is a restriction, but in Western world, with availability of long-acting factors, which can be given as prophylactic once in a 15 days or once in a month, usually they are leading a normal life nowadays. Because only thing which differentiates between normal and hemophilia is a factor deficiency. To replace the factor, they can lead the normal. But with good factor availability and patient awareness, nowadays better things are available. So usually they should take care that they don't bleed, take factor at proper time, keep oneself aware about disease and what are the precautions needs to be taken, and usually they can lead a normal life. Yes.
Okay, thank you so much, sir. It was really well explained, sir. We will be taking last two questions I can see here for today's session. And the question is, how is the number of unit of factors 8 needed to be correct the factor 8 activity level in hemophilia A determined?
Very important question. Usually, depending upon the joint bleed and severity of bleed, we decide. The factor is calculated as per the weight. Usually, 1 unit of factor replaces or increases factor level by 2%. So, if someone is 50 kg in the weight and joint bleed is there, for joint bleed, we give 30% correction. For severe bleed, we give 40-60% correction. And life-threatening bleed, usually we need 80 to 100% correction. So considering more common joint bleed, 30% correction we are planning. So 15 to 30 is usually 1,500 international. As it increases the level by 2%, we have to divide it by 2. So 750 units should be the one dose, which should increase the factor level by 30-40%. Usually 750 units, one dose we give, that is good enough if small bleed is there. But if it is a good amount of bleed, we have to replace it every 12 hourly or at least 2-3 days. So usually we give 750 units one dose followed by 500 units every 12 hourly for 4 to 5 doses. If it is severe intracranial bleed, someone is 50 kg weight, 100% correction, let's give 100 into 50, 5,000 divided by 2. That means 2,500 units, right? Followed by half of that dose, that is 1,212 hourly for 7 days if it is intracranial bleed. For factor 9, no need to divide by, we have to give full dose, but then we have to give it once in a day only. Once in a day is good enough because factor 9 has long half-life of 18 to 24 hours. Factor 8 has 8 to 12 hour half-life. That is why it needs to be replaced 2 times in a day. So this is how we calculate the dose. Thank you.
Thank you so much, sir, once again for explaining it really well. I hope that participant have received his answer. I can see one last question, sir. The question is, what are the physical finding characteristics of hemophilia A after a immediate neonatal period of?
After,
So the question is after a immediate neonatal period.
okay, thank you so much for asking this question. Usually, as I have already told, hemophilia A usually comes with a joint bleed and usually manifest when kid is around 1.5 to 2 years. When they start walking, they start developing bleeds in the joint. Factor 13 deficiency, factor 7 deficiency, factor 5 deficiency, they can come early in neonatal period only, like the bleed from the mouth or GI bleed or bleed from that stoma. It can be there when other factors are deficient. Whenever it is umbilical cord bleed, if it is usually hemophilia, it comes at the age of 1.5 to 2 years when child starts walking. This is all. Thank you.
Okay, thank you so much, sir, once again, sir, for answering all the questions, sir. And it was a really wonderful session on the day of hemophilia. And I hope that all the participants who have joined are really active and going to get knowledge from this session, sir. Sir, we don't have any questions, sir. Shall we conclude this session with all your permission?
Yes, Taras, thank you so
Okay,
much.
thank you so much, sir. And it was a really wonderful session and hope to see you again with different topics, sir. Until then, take care of yourself, sir. Have a great day ahead.